Welcome to ESD School, brought to you by ATRACT. Don't forget to subscribe to the channel so you don't miss a single episode. Enjoy the video.
Welcome to this ESD School by ATRACT. We are here for this first introduction to present you why ESD is a good technique for the patient, why you should invest yourself in the training, and how you could be trained to master the technique. In fact, ESD is an amazing technique, but needing high technical skills, and therefore it is crazy to begin in human without modelization and simulation before. We are here to present the results of the training without simulation, but also how you can master the technique with simulation. And this first introduction just want to justify the need for this ESD school, and later you will have a lot of episodes trying to explain each part of the procedure and trying to give tips and tricks to help you to be more effective and more safe in the practice of ESD. We hope you will listen it with a good feeling and that it will help you. Thank you very much to be here. First, we will discuss about the theory, why ESD is for us better for patients, and why we should spread out this technique compared to piecemeal EMR or the surgical alternatives. The second point is that there is probably no future for ESD without a good training and without innovations to improve the easiness, the speed of dissection, and also the safety to spread the technique more quickly and to spread it even for physicians that are not only dedicated to endoscopic resection. We will discuss about the important steps of training described by the ESG curriculum, and practically we will present the result of the French ESD training program proposed by our French Society of Digestive Endoscopy. We will present the results of this training, and we will discuss about what we offer with this ESD School by ATRACT to help you to train in ESD more easily with an accessible and virtual tool. So first, why we strongly believe that ESD is better for patients. First, endoscopic detection of T1 cancer is not easy. This is an example of a lesion sent by a friend. He sent me good picture of the direct view of the lesion, but when we did the retroflexion, there was a cancer that was covered by adenoma that was not so easy to determine and to detect within the lesion, but EMR was probably not a good option for this lesion that was in fact a T1 cancer with a submucosal invasion of less than 1000 micron, because in fact the risk of damaging the posterior area of the lesion with the snare was probably not null. And thanks to these new scopes, these strategies to see the whole lesion, you can detect this cancer. But another way to be sure of the quality of your resection, preventing the risk of cutting in several pieces T1 cancer, is to choose more largely an unblocked R0 resection by ESD when you're not sure. The second point is that ESD is better because T1 cancer is really easy to miss within a lesion if you don't spend a lot of time with a slow and attentive examination. And this was an example of a lesion that seems to be nodular, but in fact there was a cancer, really demarcated one, not very big, because entering in the cap, so less than 13 millimeter. The pattern was quite destroyed at the middle. We classified it 5N in the center, but in a small area of less than 10 millimeter. We usually attempt diagnostic ESD in order to get specimen to have a precise pathological assessment to be sure that there is no way for the patient to have only an endoscopic resection and a follow-up instead of a systematic surgery. But unfortunately, in this case, during diagnostic ESD, we could discover a small invasion in the muscle, and it was in fact a T2 cancer. But the physician who sent the patient to us for the resection didn't see at all this small cancer within the lesion, because depending on the position of the patient, on the time you spend to try to find this demarcated area, you can easily miss this kind of lesion. And doing a piecemeal EMR on such a lesion is probably dangerous because there is a muscle fixation, and also is probably bad for the patient because you can miss the cancer diagnosis if the sample that is the only point where there is an invasion in the submucosa has not been sent to pathologist, or if it has been damaged by the piecemeal resection. Characterization is not an exact science, and therefore we have seen with the results coming from Netherlands, for example, that it is easy to miss a T1 cancer, but it is also easy to under diagnose T1 cancer. In this lesion, the area that seems different was clear compared to the whole lesion. The vessels were large and irregular, but not destroyed. So for me, it was only a Sano 3A lesion, or possibly a pattern which was quite irregular, but not so much. And we chose ESD because any risk factor for us is a good indication for ESD. And it was finally a 220 microns invasion in the submucosa with no lymphovascular invasion, no budding, and finally the patient was cured thanks to this en bloc R0 resection. So spend time for diagnosis, but if you are not sure, or if the lesion is not so easy to diagnose, ESD is a good way to avoid misclassification, and to get a good histological assessment in order to be sure of the histology of the lesion. These are the results of the Netherlands group, the Dutch group on T1 colorectal cancer, that show that sensitivity in the Dutch program to detect T1 cancer was only 80% and only 60% of sensitivity over T1. The specificity is good, but T1 cancer is missed once for 5 T1 cancer, despite the fact that the incidence was high in this study, because 36 T1 cancer were present in this 347 lesions. So despite the fact that there was a lot of T1 cancer, the sensitivity is not so high. So choosing ESD is a good way to avoid under treatment by piecemeal EMR for a T1 cancer. Choosing this high quality resection like R0 avoids different problems. With piecemeal EMR, all the pieces are not retrieved. We did a randomized prospective study comparing ESD and EMR, and in fact, only 80% of the cases we get the same number of pieces sent to the pathologist than the number we cut in the patient, but we have also around 10% of the patient where the number of pieces is higher than the number of pieces cut into the patient. That means that some pieces are divided, and in fact, being sure of the whole volume of the lesion sent to the pathologist is absolutely not sure, and it's a problem because automatically, if you don't send everything to the pathologist, the whole cancer is not examined. With piecemeal EMR, pieces are not oriented for the pathologist, so it is far more difficult for them to know the clear depth of invasion, the presence of budding of lymphovascular invasion, and therefore it is for them a kind of nightmare compared to a good specimen with margin oriented. The cancer can be damaged by the piecemeal EMR, and sometimes it leads to an impossible or approximative histological assessment. That's why ESD is probably the best way to obtain the better pathology examination of the lesion, even if this better examination is not perfect, because conventionally in ESD, the pathologist will do slices every 2 millimeter, and depending on the pathology unit, it will be a cut of 6 to 8 microns every 2 millimeter. It means that 0.4% of the lesion is really examined. If we take surgery, usually it is only one cut every 5 millimeter. So you reduce again the quantity and the volume of lesion which is really explored. But in piecemeal EMR, no piece is oriented, and it is a kind of nightmare for pathologists to know exactly. For example, on this piece, they will have only cancer. They don't know where is the surface, where is the depth, what is the depth, are we into an invasive cancer in the submucosa or only a mucosal one. It is quite impossible to be sure in some of the pieces that contain only cancer. This is an example using a more natural vision. If you do ESD, you have this kind of good slices where you can see the depth of invasion and the presence of budding. With the surgery, you have the benefit of having the muscle. So it's better for the lesion that goes to the muscle for T2 and T3 cancer. For only submucosal lesion, no real benefit of surgery for a T1 cancer, and if there is no risk of lymph node metastasis. But in piecemeal, you lose a lot of information, and it is very difficult for the pathologist to find really the lymphovascular invasion. And in our study in France, finally the rate of T1 cancer was higher in the ESD group than the EMR group, probably because we lose a lot of pieces during the piecemeal process. ESD is better for patients also to reduce the risk of local recurrences and the number of follow-up colonoscopy, because if you are R0, the follow-up at 6 months is not useful because the rate of recurrence is 0. But with piecemeal EMR, despite the fact that this rate of recurrence has been really reduced by the destruction of the margin with the tip of the snare, this rate of recurrence is low, and under 5%, but it's not null. So you cannot avoid the follow-up colonoscopy at 6 and 18 months after piecemeal EMR, despite the fact that the rate is low. You should be aware that some recurrences will come. Recurrences are rare, but difficult to treat. And usually, when you have a recurrence, the patient should be sent to an expert center again to be treated by FTR or ESD. And in case of recurrences, the patient will totalize a high number of colonoscopy. The initial one, the resection one, the first follow-up, the resection of the recurrence, the follow-up at 6 months after this recurrence treatment, 18 months, and finally, it is a lot of procedure for the patient. So ESD again is the best way to reduce the number of colonoscopy procedure because with the R0 resection, you will reduce the number of follow-up needed in the future. This is the result of the Resec colon randomized trial. R0 was 94% in the ESD group and 6% in piecemeal EMR. Recurrences were 0.6 and 0% if R0 resection compared to 5.1 of recurrences in the piecemeal group, despite the fact that we destroyed the margin with coagulation. The duration was longer, it's true. The surgery complication for adverse event was higher, but the T1 cancer was clearly increased compared to the piecemeal EMR, demonstrating that probably we lose information with piecemeal EMR. And it could be also more ecological to have a other resection by reducing the number of way of the patient to the hospital for the follow-up in the future. Second point, there is no future for ESD without a proper training and probably traction. Beginning in humans for ESD is not effective and it's dangerous. This was the French first prospective study published a few years ago. Non-trained physicians described their experience in ESD at the beginning of the experience with a very low R0 resection rate, 52%, and 34% of perforation. So no way for beginning ESD in human without a proper training before. No future also for ESD without innovation. The technique was described 22 years ago in the column, and it is still really difficult to spread out because ESD needs to be easier. It is important to reduce the learning curve and facilitate the spreading to people who are not only dedicated to this technique. It is demanding, but we could also make it more simple to spread the lesion. It has also to be faster because procedure duration is an important limitation in Europe. We need to treat a lot of patients. We have not a lot of means because the endoscopy schedule should be shortened. We have no personnel to open the doors of our endoscopy theater for 12 hours a day. So we should reduce the procedure duration in order to get this R0, but with acceptable duration compared to piecemeal EMR. This is obtainable thanks to traction strategy, knives, solutions, new strategies. And finally, it has to be safer by reducing the difficulty and also, very important, by training people to manage their adverse events alone. If we are able to treat our bleeding and our perforation by ourselves, in fact, a perforation is not really a complication. It's an adverse event we can treat by ourselves without further surgery. And this has to be trained. And that's why we think that an ESD school training in all these aspects to make it easier, faster, and safer is very important to spread out this technique, which is also wonderful and very good for patients. The important steps of training now, it has been described by ESG in the training curriculum with several points. You should have a background. You cannot begin your endoscopy with ESD. It's impossible. You should know advanced diagnosis. You should have colonoscopy skills by turning the scope, by torquing, by knowing the loops, etc. And you should know the adverse events in order to be able to deal with when you will have an adverse event. The knowledge of ESD is very important, and compared to 2001 when they described the technique, we have now a lot of results with new devices that make the procedure more effective, using traction strategies in order to have a left end to open the space and make the exposure better. And we have a lot of theory to improve the technique and reduce, for example, the water leakage to have a mucosal cushion that stays in time and helps you compared to before where they did a circumferential incision with a lot of leakage. Observation is very important at the beginning, observing experts, but also being assistant of this expert, because at the same time you will also be trained in the long-lasting procedure, and you should be prepared for this long-lasting procedure compared to our usual endoscopy schedule, where the procedure is usually under 30 minutes. Simulation is very important to be trained on the hands-on parts technically, to get the skills on models, on traction, and also to deal with the adverse event. First human experience should be selected with a good organization of the unit, a good communication with your surgeon, with your pathologist, etc., and with a supervision from an expert. And in routine practice, you should record your own database with a progressive difficulty, and you should continue your training during the first human procedure because, in fact, it never stops. There is a strong debate. At the beginning, the two Japanese who described the technique, Yaagi sensei and Saito sensei, did a circumferential incision with a lot of leakage. The device were not dedicated to ESD. The scopes were not dedicated. There was no cap, etc. So it was very difficult, horrible. And the speed of dissection was very low at the beginning. Now we have guys who have been trained really strongly, but from the beginning, without piecemeal EMR experience before. They use adaptive traction. They have been trained in strategies, in training. They had a very quick learning curve, and now they reach a very high speed of ESD in a very recent study. Timothy reached 75 square millimeter per minute. So it is possible. And a lot of people did it in France in reality, but with a proper training. We have three different things. For Professor Ponchon, the way, when it is difficult, will train you. And he says, do you think I could be so strong if somebody explained to me how to do it? By understanding it by myself, I could be so good. Okay, but my own position is that we have spent a lot of time, Japanese before and us now, to make the procedure more easy, to understand the strategies. And I don't think that we should absolutely reproduce all the mistakes we did to be trained properly. And probably the solution is in a compromise between you should have a long way because it's not easy to get this very demanding technique. But on the opposite, don't refuse to use the innovations like traction because it is evident that having a left hand to open the space is something helping. The surgeon are not trained working with only one hand to be better with two hands at the end. They use one to open the space to make the triangulation and the second one to cut what they are tracting. So, okay, you should have a long way, you should train hard, but on the opposite, don't be totally close to use the new strategies and the new innovations that make really easier and really safer the ESD procedure. So now we will discuss about the French ESD training program. So for us, ESD is the gold standard to achieve R0 resection for superficial neoplasia. But without training, the results are not acceptable. So we cannot avoid training, but the learning curve is long and difficult. The curriculum proposed by ESG in October 2019 did a selection of candidates, a theory education, simulation with animal models, and supervision for the first human experience. To realize it, French Society of Digestive Endoscopy decided to propose a French ESD training program and ask us to organize it for France. We did a selection of 16 trainees, despite the fact that the number of people who applied to the training was 35. We decided to choose people about their motivation, their ESD background, the volume of the center, the training center of more than 50 cases a year, an expert supervisor that was engaged in training, and we tried to cover all the French territory during the 3 first years of the training. We also tried to choose people with high technical skills after seeing them working during workshops or this kind of. We present here the results of the French ESD training program. We did a theory pre-test and 6 webinars about diagnosis, strategies, indications, how to fulfill the curriculum, the devices, and the adverse events. After they had a practical pre-test in Limoges during a 1-week simulation training. They were trained during the full week about different parts of the procedure. And at the end, we did a theoretical and practical post-test. We created a social network of all the students involved in the first year. And after, they went back to their center with the mission to perform at least 20 ESD procedure during the first year with the supervision of an expert. So the hands-on training week in Limoges was divided in a first half day with 7 stations of practical tests about marking, incision, trimming, dissection, ESD with traction, tunneling, closure, and skills in the skill box. We did also a score called OSATS endoscopic, which is a kind of score derived from the surgical score of ability. During the half days between the 2 and the 8, they were trained on 7 stations. They did ESD with their hands. We did video analysis of what they did, filming them to try to correct the bad position, the bad things. We worked on ergonomy, on the difficulties. They were trained by 14 different experts. We did debriefing every morning, and we tried to prepare themselves of the stress of this kind of procedure that can be long with adverse event. And on the last day, they had the same practical test with 7 stations and the same score of ability with the OSATS endoscopic score. The results of the training are as follow. They had an improvement in their theory test from 76 to 82, from the technical test to 52, from 52 to 70, and in the OSAT score from 59 to 83. 87% of the trainees improved their results. The 7 stations were difficult to organize, but there was quite a correlation between the OSAT score, which was done only on 10 minutes, regarding the trainee doing ESD during 10 minutes. There was a kind of correlation between the score of the OSATs and the sum of the 7 stations that are really difficult to organize. You need a full half day to do an evaluation on 7 different stations with the OSAT score. Only 10 minutes on one model is enough to evaluate somebody. After this, they went back to their unit. In mean, they did 23 ESD procedures in the year, 13 alone without the supervisor doing ESD during the procedure. Rectum and colon were very frequent, despite the fact that we recommended them to begin in the antrum and the rectum. 73% of the cases were done with supervisor in the room, and 75% with traction from the beginning. 92% of en bloc and 84% of R0 resection, but a high risk of perforation of 9%, with a very high risk of surgery of 1.4%. So this is a point that we will treat more in the future, trying to train people about how to deal with the adverse events in order to avoid surgery. Finally, only 6 trainees did more than 15 procedures by themselves, and they could have a great improvement in the speed during the first half and the second one, but only for the guys who did a lot of procedures. There was a correlation between the simulation and the real life. When the score at the post-test was over 75, 89% of the students reached 80% of R0. So it seems that a high score at the post-test on the 7 stations is associated with better results and less perforation and a higher speed. What was linked to the score at the pre-test at the beginning of the week was the number of human cases that were done during the 12 months. It means probably that if the level is very low, it is difficult for the supervisor to give the end to the trainees, and minimal skills are needed probably to make the supervisor confident to let the end for the trainee. And finally, why we should propose this ESD school. We think that there are very important steps of training that could be done remotely on virtual tools in order to save time during the hands-on training on models. In fact, if people comes to the hands-on training with a very high knowledge about theory, about devices, about strategies, about traction, if they have observed a lot of procedures remotely by seeing both the endoscopy picture but also the hands of the physician, they will probably save time in order to really participate in the simulated sessions, because sometimes we have people that comes to ESD training on models, but in fact they have not the theoretical knowledge, and we spend a lot of time to explain the theory during the hands-on training. Also, we could have this part virtually, remotely, with a lot of tips and tricks, a lot of strategies, a lot of theory explained before, and really have a very intense and effective training in models when all the theory is known. So finally, we will propose you a lot of episodes of the ESD school dedicated to one part. The first we did is about injection, which is really an important part of ESD. You can change your ESD with injection. A very good injection can make a difficult ESD easy, but on the opposite, an easy ESD can become a nightmare if your injection is very bad. We will talk about incision, trimming, dissection, traction, with a very important part of our training, about the strategies, the management of bleeding and perforation. And we will now discuss about the background you need with the colonoscopy skill, the advanced diagnosis, the adverse event, how to deal with. And we will also try to give you some keys about the training in practice, what training models are useful, how can you have this kind of models, not only animal, but now also non-biological models like Endogel, for example, and we will also give some clinical situation to test you in practice. And finally, to summarize, we are sure or convinced that ESD is better for patients, but really demanding, with high technical skills, long learning curve, strict quality parameters. The training is unavoidable. Theory, simulation, and supervision are needed, with a teamwork with pathologists and surgeons. Training is therefore unavoidable, but you should be trained both in theory and practice to spread the technique. But we can save time with a virtual training on all the theory to understand the concepts, and to save time for the theoretical knowledge in order to save this time for practical things, for hands-on training, in order to really be active during this hands-on training and avoid losing a lot of time understanding theory during this hands-on practice. ESD School wants to give an easy access to theory by virtual means, sharing all our tips and tricks, giving you a virtual supervision and training tools in order to save time for your future hands-on practice. I hope it will be of interest for you, and the ATRACT team will help me to do a lot of episodes to help you. Thank you very much.
Thank you for watching. If you found this video helpful, please give it a thumbs up, subscribe, and share it with your colleagues. Until next time, this is ESD School by ATRACT.